Rapid Multidisciplinary Needs Assessment for Patients with COVID-19 Transitioning from Hospital to Home. This is Wanda Robinson, and I am pleased to present this project to you on behalf of the team that was formed approximately a year ago during the emergence of the COVID-19 pandemic. The interprofessional team for this project is robust, including individuals from the Health Science Center campus and Norman. Amy Costner-Lark, Susan Dresser, Brandon Earl Ziegler, College of Nursing, Mickey Thompson's Advanced with OU Medicine, Heather Graham, OU Health, Carrie, Ciro, Occupational Therapy, and Shirley James, Physical Therapy from the College of Allied Health, and Terry Fritz from the Anne and Henry Ciro School of Social Work. Co-investigators include faculty, students, and clinicians. This poster presents some of the preliminary findings from this ongoing study and shares the experience of working together with multidisciplinary teams, looking at benefits and challenges according to the IPEC competencies, particularly communication and relationship building. Prolonged hospitalization for individuals with a severe acute illness impacts the overall physiological, functional, and psychosocial aspects of an individual. Additionally, transitioning from the hospital to home is a vulnerable period. Little is known about the unique needs of individuals who are surviving immediately following their discharge from the hospital. Best practices are needed to help them achieve optimal recovery while they're at home. Before targeted interventions can be planned, a multidisciplinary rapid needs assessment model can be used to identify and uncover the medical, psychosocial, and rehabilitation needs for individuals. The focus of this study was using the multidisciplinary rapid needs assessment model to identify and analyze the comprehensive health needs of individuals surviving COVID-19 in their first 4 weeks at home. This presented a great opportunity for a multidisciplinary team coordination to explore all aspects of the individual's health. Team communication was critical in planning this project. Each discipline contributed to identifying the expertise and area of assessment that would be covered. Nurses in the OU Nursing Case Management Program identified clients who were preparing to discharge into that program and obtained informed consent. The participants were then given a bag with many different biosensory devices for home monitoring, including pulse oximeter, EKG monitors, thermometer, blood pressure cuff, and activity monitor that's similar to a wristband that monitors all activity 24/7, sleep and awake and movement. Each individual also participated in video or phone call assessments with the practitioners from nursing, social work, physical and occupational therapy. Assessments included vital signs, cognition, gait, emotional status, and many other areas of self-reported functioning and observed functioning through the video conferencing. Additionally, a standardized battery of assessments were conducted. Data was collected from the medical record to identify baseline information on the individual's health and functioning, comorbid conditions that were present. Throughout this process, communication was key among the team members for scheduling meetings with the patients, with coordinating the timing for delivery of assessments, to share findings and perspectives. Many times these individuals who were transitioning home were on oxygen and had extreme dyspnea. During this time, team communication was critical. The team communicated almost daily with emails. Coordination was particularly important with these vulnerable individuals. Approximately 2/3 were discharged home with oxygen, and their level of dyspnea was significant, even to the point of them having shortness of breath speaking on the phone or in the video interviews. So the team was very conscientious to coordinate timing for the delivery of visits and assessments and allow the person rest. Many unforeseen challenges arose with recruitment, consenting, delivery of study materials, and working with particular needs of individuals in the study. This required continual communication and coordination with the team, patients, and family. Almost 3/4 of the individuals had significant levels of fatigue post-hospitalization that persisted, although it decreased over a 4-week period. Additionally, cognitive assessment revealed some deficits in immediate memory, which the patients would call COVID fog or brain fog. This also made some challenges with collecting data and required additional careful team coordination. Coordination of patient care was also arranged with an individual using the calendar and other forms of communication, such as multidisciplinary and discipline-specific notes. The multidisciplinary rapid needs assessment model uses an iterative process with patient and family and collecting assessments. This was important, therefore weekly interprofessional team meetings throughout the study were required to facilitate a more comprehensive understanding of the various assessments and perspectives, what was working, what wasn't working, and the different individuals who might have better relationship with the patient and facilitate access of other professions to the individual for assessment. Coordination for the multiple assessments and scheduling took a lot of teamwork and relationship building, so everyone was supportive of each other for obtaining the needed assessments. For example, if an individual was too fatigued after a physical therapy assessment, then the nurse might not contact them until the next day to allow the person to rest. Competency for relationship building was particularly important as the team worked together to perform effectively all these various roles of planning, delivering, and evaluating the project and the patient response to assessment. While the details and findings of the study are in progress and beyond this poster, I will mention a few practice implications, and that is the critical importance of a comprehensive assessment for individuals after they've been discharged from the hospital and prior to that, to recognize the needs that they will have at home and make recommendation for assistive devices at discharge, home care follow-up, and use the expertise of the individuals in each discipline to plan for gradual increasing activity and functioning. The need for emotional support was also quite evident. The caregiver education prior to discharge and at home was also critical, as many individuals required a lot of support from their family. Also planning for primary care follow-up and having plans in place and education to help the individual with energy conservation, activity simplification, learning basic exercises for progressive functional ability, stress relief, and management of anxiety, which continued with the person weeks after their initial discharge. Overall, as a result of the interprofessional teamwork experience, we anticipate future opportunities for collaboration and research, education initiatives in the clinical setting. We would like to acknowledge funding from the Office of the Vice President of Research at OU Norman Campus and many others who contributed to the team and were part of this project. Thank you.